Well, this is an analysis from the Disrupt CAT1 and CAT2 study, comparing patients having eccentric and concentric lesion. And we treat these lesions with coronary intravascular lithotripsy. This is the first analysis of any calcium modification technology comparing the effect on intravascular lithotripsy on eccentric versus concentric lesion. There's always a concern among interventionalists regarding eccentric lesion because during balloon dilatation, it often happens that we have a disruption or dissection of the healthy intima or the fibrous plaques rather than a modification of calcified segments within the artery. And if you look at the rotational atherectomy or the orbital atherectomy, the most effective techniques prior to the intravascular lithotripsy, these are limited due to the guide wires because they have, in some cases, a very inhomogeneous ablation, leaving significant unmodified areas in eccentric lesions. Well, this was a patient-level data analysis pooled from 180 patients in CAD 1 and 2, yielded 47 eccentric lesions and 133 concentric lesions in total. Looking at the results from a safety perspective, there was no perforation at all. We had no closure or slow flow or no reflow events in both groups, either in the eccentric as well as in the concentric group. And there was, most important, no rates of flow limiting dissections. Looking at the final acute gain and percent of residual stenosis, both were similar between the two groups, and the final minimum stent diameter was significantly greater in the eccentric versus concentric lesions. This is a hypothesis generating study, and from this initial analysis, we can see that the intravascular lithotripsy holds promise in being both safe and effective with similar outcomes in concentric and eccentric lesions. Well, given the angiographic limitations in determining the exact arc of calcium within the lesions, we know that we need further insights from the OCT and the IVUS just to have more impression what is the effect of intravascular lithotripsy in these concentric versus eccentric lesion. But this will come from the coming up Disrupt CAD clinical program trials. Well, OCT allows you to analyze the calcium depth, arc, and of course the length of a calcific lesion much more accurately than by angiography alone. We know from the risk stratifications that if a lesion has more than 5 millimeter in length calcium and more than 0.5 millimeter in depth, and an arc more than 180 degrees, so this is a predictor for an under-expansion of the stent. So this information comes from the OCT, and to have this information, this allows you to develop an intravascular lithotripsy strategy if it's needed.